Hello and welcome to part 5 of our series Current Trends in Hypertension. Today's discussion is resistant hypertension. I am Dr. Mohammed Tinawi. You can know more about my background in the description below. How do we define resistant hypertension? Resistant hypertension is uncontrolled high blood pressure. In the old definition, over 140 over 90. New definition, 130 over 80, while taking 3 different antihypertensive medications. Those 3 medications need to have complementary mechanisms, not 2 medications of the same class. Now, 1 out of 3 must be a diuretic. So 3 medications, 1 of them is a diuretic or a water pill. Or if blood pressure control requires more than 4 medications of different mechanisms of action, then also you have resistant hypertension. I recommend that you go to part 4 of this series, Pharmacology of Hypertension. If you haven't watched this video, watch it and then go ahead and watch this one. Let's discuss the causes of resistant hypertension. You can have pseudo-resistance if you're not measuring blood pressure correctly, if the cuff size is not correct. You can have white coat hypertension if blood pressure high only in a medical setting. The most common cause of resistant hypertension by far is non-adherence to medications. Medications are not going to work unless the patient takes them, okay? So not taking medications is the #1 cause. Other causes, obesity causes resistance, and in case of obesity, really you want to add a diuretic. Physical inactivity, high salt diet, I would put that as #2 after not taking medications. So high salt diet will make you resistant to blood pressure medications. Excess alcohol intake is another common cause. Some medications like non-steroidal anti-inflammatory medications, ibuprofen, naproxen, etc. Sympathomimetics like decongestants, amphetamines, cocaine is very common. We see many patients in the emergency department, really high blood pressure. I always do a drug screen, and many times cocaine is positive. Oral contraceptives can raise blood pressure. Licorice, whether it's in a drink or whether it's in tobacco, like chewable tobacco. Ephedra, many people use that for weight loss and other purposes. All these medications can raise blood pressure and cause resistant hypertension. Sometimes you have resistant hypertension because you have not discovered a cause, a secondary cause for blood pressure. These are the 4 most common secondary causes of high blood pressure. Renal artery stenosis, when you have a blockage in one of the kidney arteries. Primary aldosteronism, when you have a benign tumor producing aldosterone in one of the adrenal glands. Pheochromocytoma, this is another adrenal gland tumor that produces norepinephrine or epinephrine or dopamine that raises blood pressure. Another common cause, especially with obesity, obstructive sleep apnea. What can we do about management of resistant hypertension? Obviously, we have to address the cause. If someone is not taking medications, well, they have to take their medications. If the patient is not on a diuretic, well, they should be on a diuretic. If someone is eating too much salt or drinking too much alcohol, they should stop doing so. So first, you need to optimize diuretic treatment. So if the patient is taking maybe 12.5 milligrams of hydrochlorothiazide, consider 25 milligrams. If someone has chronic kidney disease and it is advanced, consider a loop diuretic like bumetanide or furosemide. Now, another helpful medication is spironolactone. So a mineralocorticoid receptor may help even if you don't have primary aldosteronism. You have to be really careful with patients with chronic kidney disease. Anyone with tendency for hyperkalemia, you have to be careful about adding spironolactone. Now, make sure that the antihypertensive medications you're using have different mechanisms of action. Do not use amlodipine and nifedipine on the same patient. Do not use amlodipine and verapamil in the same patient. Do not use, and I see that very commonly, unfortunately, minoxidil and hydralazine in the same patient. Those have the same mechanism of action. Again, go back to part 4 of this series. I'll provide a link for pharmacology of antihypertensive medications. Now, when all fails, minoxidil is sometimes helpful, and that should be used only by a hypertensive specialist due to numerous side effects. Sometimes clonidine may be helpful. Sometimes an alpha blocker, I find it helpful, like doxazosin or terazosin. And definitely you should, at that point, once the patient is taking more than 2, 3 medications, you should consider referral to a hypertension specialist. That can be an internist with a special interest in high blood pressure, can be a nephrologist or a cardiologist. Okay, this is another 5-minute video. I hope that was helpful. Please subscribe to this channel, like the video.